So good afternoon and welcome to this briefing from number 9 Downing Street. It's very nice to see people with us in person for the first time in many, many months. So welcome, journalists. It's really nice to have you in the room. I'm Jonathan Van Tam, Deputy Chief Medical Officer, Department of Health and Social Care. Today I'm joined by Dr. June Raine, Chief Exec of the MHRA, the Medicines and Healthcare Products Regulatory Agency, the UK regulator, and also by Professor Wei Shen Lim, who is the Chair of the JCVI, Joint Committee on Vaccination and Immunisation, COVID-19 Vaccines Subcommittee. Thank you all for joining us. Today's briefing is a technical briefing about updates to the UK vaccination programme for COVID-19. And if we can, we'll keep the conversation strictly to that subject. So after those opening remarks, I'd like to first of all pass to Dr. Raine to update you all on the regulatory position with regard to COVID-19 vaccines and children and young people.
Good afternoon. The Medicines and Healthcare Products Regulatory Agency, the MHRA, as the independent regulator for all UK medicines and vaccines, is responsible for approving COVID-19 vaccines and ensuring that they meet robust standards on safety, on quality and on effectiveness. And as I've said before, and I'll say it again, your safety always comes first. Since approval of the COVID-19 vaccine Pfizer-BioNTech in December last year, substantial experience has been gathered on its effectiveness and safety. And most recently, the results of randomised, placebo-controlled trials in children and young people aged 12 to 15 years were rigorously reviewed by our teams of scientific and clinical assessors. In addition, we have data on neutralising antibodies that show how the immune system responds to the vaccine. And all of this shows that it is effective in the same way as we see in adults aged 16 to 25. So taken together, this meant that the vaccine could be approved for use in young people 12 to 15 years. Data on safety of COVID vaccine Pfizer in 12 to 15-year-olds have also been reviewed very carefully. The safety data in adolescents was comparable to that we've seen in young adults, and no new adverse events were identified. As in young adults, the safety profile showed mild to moderate reactions in line with the way that the vaccine works, perhaps a temperature, sore arm, headache, that kind of thing. We've also sought independent scientific advice from the Commission on Human Medicines and its Paediatric Medicines Expert Advisory Group on the safety, on the quality and on the effectiveness in this population. And the conclusion, by consensus, has robustly been that the benefits outweigh any risks. And on this basis, the Pfizer-BioNTech vaccine was approved for use in children aged 12 to 15. Our work doesn't stop there. The MHRA has continued to scrutinise all suspected side effects data received through our rigorous surveillance programme in place, largely through the yellow card scheme, but with other sources of data used in a proactive way to continue to monitor benefit-risk balance. Of course, we welcome reports of any suspected side effect through our yellow card scheme. So a big message there, please do report. But overall, our advice remains that the benefits of getting vaccinated outweigh the risks for the majority of people, and the vaccine benefit outweighs the risk in children and young people aged 12 to 15. Back to you, JVT.
Thanks, June. I'm now going to pass to Professor Lim to make the announcement over JCVI's latest recommendations to the government.
Thank you. Last month, you may remember, JCVI provided initial advice regarding vaccination of children and young adults aged 12 to 17 years old. And today we are updating that advice. I'd like to start by mentioning an important point from the very outset. When considering vaccination programs for children and young people, JCVI's main focus is the balance of potential benefits and harms for the individuals being vaccinated. Vaccination of children and young people can bring benefits to other people, such as adults, and including parents and grandparents. But at the forefront is the health and the benefits to children and young people themselves. When formulating this advice and our latest review, we took into consideration a range of other factors and the very latest information. And I just want to run through some of the many different factors we considered. The first is the frequency and severity of adverse reactions following vaccination, and Dr. June Rain has commented on this already. There's also the impact of delivering COVID vaccines to children and young people on other school-based vaccination programs. These include meningitis, for instance, or the influenza vaccinations. We looked at the frequency of severe COVID in children and young people in particular. Thankfully, it's extremely rare or very rare for bad outcomes to occur. And that is good news for children as a whole. The occurrence of what is called long COVID or post-COVID syndrome was also a consideration. You will know that some people with mild symptoms of COVID during the acute episode do go on to develop symptoms that are of longer term. Again, thankfully, this is only true for a very small proportion of children and young people. Perhaps more difficult to measure are the mental health and educational impacts of COVID, and we tried to take those into consideration as well. We looked at mathematical models of the impact of vaccination of children and young people on the wider population, and these would be the benefits that perhaps adults might gain in terms of infections or hospitalizations. And then lastly, we mustn't forget that the pandemic has disproportionately affected certain people. And so one consideration is always, what is the impact of vaccination on reducing health inequalities? A particular point to remember throughout all of these is that there's a very strong influence of age on the risks associated with COVID. We know this for adults. We know that older adults are at higher risk than younger adults. It is also true for children and young people. And therefore, a 16-year-old child would be at higher risk than a 13-year-old child, for instance. That means in general terms, the benefits of vaccination are typically greater for older children compared to younger children. And that point needs to be borne in mind. Taking all of these factors into consideration, there are 4 points of advice I want to highlight. The first is to reinforce that adults 18 years and above should be vaccinated, and we strongly advise that they are vaccinated. The benefits outweigh the potential harms. I am a chest physician. At the hospital that I work at, we are now seeing young people who are unvaccinated being admitted to hospital with quite severe COVID. Many of them need oxygen support, and sadly, some of them also need a ventilator machine to help them to breathe. Much of that suffering can be prevented or reduced through vaccination. And so my urge to adults who are 18 years and above who are not yet vaccinated is that you strongly consider booking your vaccine appointment, having the jab, and getting yourselves and your friends and family protected. That's the first piece of advice. The second relates to healthy 16 and 17-year-olds. We would like to advise that the first vaccine dose is offered now for 16 and 17-year-olds who are otherwise healthy, with the aim of a second vaccine dose to be offered sometime later. And we will provide another update of advice regarding the exact details of the second dose. The reason for wanting to provide advice on the second dose separately is because we're expecting more data to accumulate in the coming weeks. And that means that we can offer advice that is the most up-to-date and the most relevant for the second dose for this particular age group. I'd like to reflect that you may remember in the UK at the end of December last year, we chose to use a 2-dose schedule with an extended dose interval between the first and second dose. By doing so, that allowed us to prioritize first doses and have more people protected. We also know now that by extending the interval between the doses, we achieve a higher level of protection, which can translate into a longer duration of protection. With regard to the current advice, the extended dose interval means that we are in a position to offer advice on the first dose and still have time to look at new data as they accumulate before second doses are due. Other countries that have chosen to use a 3-week interval between their doses will not have this option quite so readily available to them. And that is maybe an important difference. This advice for healthy 16 and 17-year-olds is new and is in addition to the existing advice for 16 and 17-year-olds who have underlying health conditions that put them at risk of severe COVID. They have been eligible for vaccination for many months now, and I hope most of them have been vaccinated. The third point of advice is for children aged 12 to 15 years old. We offered advice for the last month in July, and that advice is unchanged at this time. Just to summarize, there are two groups of people in the age bracket 12 to 15 years who are advising vaccination for. These are people with specific underlying health conditions that put them at risk of severe COVID, and also 12 to 15-year-olds who are close household contacts of a person who is immunosuppressed. And this is because immunosuppressed persons may not be able to generate a good immune response even if they themselves are vaccinated. As I said, this advice is unchanged from July. The last and fourth piece of advice that I'd like to put forward today is I'd like to highlight the importance of other immunization programs that are routinely offered to children and young people, such as meningitis, human papillomavirus vaccines, and the influenza vaccine. As we increasingly return to life as normal, we need to catch up on these other vaccine programs as well. And so I would say that if you are eligible for one of these vaccines and are offered these vaccines, please do not ignore them just because we're in a pandemic. They are important and they are safe. Thank you.
Thank you, Professor Lim. I think at this point we've said all that we wanted to say, and that we can now open the floor to questions from the assembled journalists. And the first on my list is Sancha Berg from the BBC.
Yes, thank you very much. I appreciate that you have explained in some detail how you reached the decision on 16 and 17-year-olds, but a lot of this data must have been available before. So I wondered what it was exactly that made you change your mind now with regard to 16 and 17-year-olds. What was the deciding factor? And a couple of very quick ones. Will parental consent be needed for 16 and 17-year-olds? And when do you think this will start? Thank you very much.
Okay, Wei Shen, would you like to possibly do the first two, and I will take the start of the programme.
Thank you. We last looked at data at the end of June and the early parts of July. And at that time, there were emerging reports of myocarditis, which is inflammation of the heart muscle, following vaccination with the Pfizer vaccine. As you know, the information available is partly dependent on the number of people who are vaccinated. And as the weeks go by, many, many more people are vaccinated. So the difference is not new data in terms of new data coming from elsewhere, but a greater certainty of the data as more data increase. We also obviously reviewed other data points, and I've mentioned earlier all the other factors we looked at. We mustn't forget that the summer wave, as we're experiencing now, was also quite uncertain about 4 weeks ago, and now we have more information on that. So it's not just new data on one point, but it's new data across a range of factors that influence advice. On your second point about parental consent, in the UK, a person who is 16 years and above is deemed able to consent for themselves, and if they are competent and able to consent for themselves, then that consent holds.
Sancho, on the point about when this is going to start, obviously children are going to start going back to colleges and sixth forms from September, and in Scotland that will be actually, I think, slightly earlier in some cases. So there is no time to waste in getting on with this. Now we have the JCVI advice on starting that initial first dose in 16 to 17-year-olds, then I want us to proceed as fast as is practically possible. That isn't going to be tomorrow. I don't think it's likely to be early next week, but I can tell you that the NHS has been kept informed of what has been being deliberated by JCVI. It has been preparing for multiple permutations and options for very many weeks now, and I would expect that this programme will start in a very short number of weeks, as opposed to any longer than that. Were there to be any question marks about vaccine supply, there is a plentiful supply to meet any of the possible permutations that JCVI could have come up with independently, and indeed the JCVI advice has not taken into account any kind of rate limiting factors related to supply. That is not an issue at all. So we have the supply, and I'm expecting this to start within a very short number of weeks indeed. Thanks. Ashish Joshi.
Hello, thank you. Dr. Rain was talking about the safety of the vaccines for 12 to 15-year-olds. Professor Lim, you're talking about some very sick children being admitted to your hospitals. Is this then not a missed opportunity? If it's a safe vaccine for that cohort, the 12 to 15-year-olds, and you're saying you're seeing some very sick patients admitted, would now not be a good time to start including them in your programme ahead of the autumn term, not only to protect those children, to break that chain of transmission in the classroom?
Weishan, would you like to take that one?
Yes, thank you. We are indeed concerned for the health of 12 to 15-year-olds as it pertains to COVID. And you will remember that our advice is that 12 to 15-year-olds who have underlying health conditions should be offered the vaccine. We know from data from the UK that the vast majority of 12 to 15-year-olds who become seriously unwell are those who have underlying health conditions in the first place. And so by offering vaccination in a targeted manner, we will be protecting the vast majority of 15-year-olds. What we haven't yet decided definitively on are the otherwise healthy 12 to 15-year-olds who are at very much lower risk of some of these severe outcomes we're talking about. And we will review the data, and if the data allow, then we will obviously want to try and protect them with vaccination as well. But that's a decision we can't make at this point, or rather prefer not to make at this point.
I think I'll just add to the remarks to that question to say that at the moment, if you look in the UK's immunisation guide, the Green Book, it's available online, you will see that among children to 12 to 15 years of age, the targeted groups for COVID-19 vaccination are children with severe neurodisabilities, Down syndrome, underlying conditions resulting in immunosuppression, and those with profound or multiple learning disabilities, severe learning disabilities, or those who are on the Learning Disability Register. We have asked JCVI to continue to review that list on an ongoing basis, and my sense is that it is more likely rather than less likely that that list will broaden over time as data become available. The next question is from Emily Morgan.
Thank you. Can I just be really clear? Did the benefit-risk ratio change in the last 2 weeks for vaccinating 16 to 17-year-olds? And if I may, Professor Van Tam, you once famously said that you would encourage your own mother to have the vaccine. If you had a 16-year-old child, would you be encouraging them to have it?
Thanks. So I'll try and give an illustration as to what we mean by certainty of information, because that's how we're making advice, or giving advice. It's based on how certain the information is, not just on the balance of harms and benefits. So if you imagine 2 dots, and if we are very certain about the 2 dots, and imagine the points of my fingers as the 2 dots, then they will appear as 2 dots, and we can tell that these 2 dots I'm holding up are quite far apart from each other. If the information is less certain, then what we really have is some fuzziness around the certainty of the information. So imagine it's not a dot, but it's a hand. If these 2 hands are far apart enough, you can tell that they are far apart. But if we have 2 dots that are close to each other, and the information is fuzzy, then it will look like that, and it's more difficult to tell separation between these 2 dots. And that is the difference between certainty in the data that we have over time. So as time goes on, we have more certainty regarding the size of these data points. The data points may not actually change where they are, but if the certainty increases, we are more certain about the separation between these 2 data points, and therefore we can be more certain about the advice. I don't know whether that helps you.
Yes, so your question to me, Emily, was about 16 to 17-year-olds. So I have 1 child who's an adult. I have 2 children who are younger than 16 and 17. However, I would be very much in favour, based upon the adjudication of JCVI, if they were 16 or 17, for them to be vaccinated initially with that first dose, as JCVI has said. All of the adults in my known family group have had all of the COVID vaccines that they are eligible for. I'm a strong believer that these vaccines are safe and effective. I'm a strong believer that they are changing how we can learn to live in a much more normal way with COVID-19 for the foreseeable future. The next question is from Chris Smith at The Times.
Hi, thank you. Firstly, can I just follow up on your answer about those dots? Can you put some numbers on those risks and benefits for this group? Because 2 weeks ago, you seemed to be saying that the risks outweighed the benefits. Are you now saying that actually, now that the confidence intervals have narrowed, that is not the case? And can we actually have some numbers there? Because I think people are a bit confused about this change in advice. And secondly, to follow up your words about those aged 12 to 15, can we infer from them that it is looking likely that in time you will be looking to recommend vaccination for healthy children in that age group, but you just want a bit more time to be sure of the data in that age groups as you have done for those older teenagers?
Thank you. I think we'll start by your second comment, which is having more time in order to be surer about the data. And that's what this is all about, is being as sure as possible so that we can move forward safely. We are, as you can imagine, being cautionary in the way we're approaching this. And that's because we place a very high value on the safety of our children and young people. And I believe we do that rightly, and that reflects the public viewpoint as well, that we should regard the safety of our children and young people very highly. Regarding those dots, it's not a simple balance of one number against the next number. I've listed to you the large range of factors that we consider when coming up with advice. Some of those things cannot be measured or boiled down into a single number. And so it is the overall sense from the committee as to whether something is more beneficial or more harmful, taking into account a range of issues. And so I'm reluctant to respond by saying it's this number against that number, and that's as easy as it goes. because then I don't think you would need a wide range of experts to come up with advice.
Yeah. So I'll just add to that a little bit, if I may. So that JCVI was founded in 1963. It has been the trusted custodian of the entire UK immunisation programme since that date. There are 16 voting members and 4 co-opted members of the committee. If you add, on a very conservative basis, their experience, and I know it to be wrong for some of them, it's much greater than that, if we kind of average them 20 years of experience, then every time this committee meets, there is 400 person years of experience sitting around the table considering the evidence. That's a lot of expertise. They are committed to evidence-based judgments and evidence-based practice. We are committed to having an independent JCVI that gives us that kind of advice. I think Professor Lim's explained that there is time to go very carefully and very safely on this, and there is time to go at the speed of science and never faster than that, and that is the intention here. The remarks that we have made about 12 to 15-year-olds absolutely stand in terms of those risk conditions where JCVI has made the pronouncement, and absolutely stand in terms of JCVI having been asked to continually review the list of people eligible 12 to 15 in those high-risk categories, and we will give them the time to arrive at a further view when they are ready to arrive at it in terms of healthy 12 to 15-year-olds. So I think I wouldn't want any of you to come away from this press briefing feeling that anything is ruled in or ruled out other than taking our time and proceeding very carefully and thoughtfully. Thank you. The next question is from Martin Brown at the Express.
Thank you. Can I just ask if the evidence will be published for parents and others to look at? Secondly, how quickly do you think all first jabs could be delivered by to 16, 17-year-olds, perhaps by Christmas? And finally, by the mass vaccination programme, getting younger and younger ages, could that compress the virus into perhaps producing a variant that's more susceptible to children in younger ages?
Okay, would you like to start, Wei-Shin?
Sure. Your first question was about whether the evidence will be published, and indeed the intention is for all the evidence to be published. The evidence isn't necessarily in the hands of JCVI. We have spoken to academic partners and to other people in other countries as well. So wherever possible, we encourage that the evidence is published, but the timing is not in our hands.
What was your second question, Martin?
Just on the speed of administering the first jab.
Oh, yes. So you asked the question which I can't answer as I'm not a deployment specialist over how quickly could the initial doses of the 16 to 17-year-olds be achieved. If you think about the school's programme for live attenuated influenza vaccine, the nasal spray vaccine, it's many more than just 2 school years who we managed to largely cover in less than a term. Now, granted, a nasal spray is easier to give than the current format of COVID-19 vaccines. It's a bit quicker to get down the list, as it were. But even putting that aside, it is my confident expectation that this is well achievable within 1 term. But I think I would not want to go any further than that without reference back to the deployment specialists who have honestly been thinking about this for weeks and weeks now. Thank you. And finally, Geraldine Scott from Press Association.
Thank you. Do you have any data or anecdotal evidence on the enthusiasm for the group that we're talking about today, for the uptake of the vaccine, or are you concerned that, like with that older group of younger people we've seen, the uptake might not be quite so encouraging?
Thank you. So we've wanted to hear from children and young people themselves as to what they think. And a lot of the feedback we've had is that they would like to have the choice. So they like to be offered the vaccine, understand the risks and potential benefits, and therefore make a choice for themselves whether they want to have it or not. We've certainly heard from groups of people who say they definitely want to have the vaccine. So I don't think there is, if you will, a fear of the vaccine or any lack of confidence. But as you can imagine, there will be people who choose not to have the vaccine. And that is entirely reasonable as well for them. If they want not to have the vaccine, then that is their choice as well.
Thank you. So I'll just wind up, I think, after that last question to say thank you for coming along in person. It really is nice to see some of you for the first time in many months. The summary I have for you is that JCVI is independent, and we're very proud of that. It has spoken on the next steps on the UK COVID-19 vaccination journey. It is now full speed ahead on getting that initial dose into healthy 16 to 17-year-olds with no underlying risk conditions. There is time, still plenty of time, as the data emerge to consider the best option for second dosing in 16 to 17-year-olds, and we will give JCVI the space to do that. There is time to continually review the emerging data in the context of healthy 12 to 15-year-olds, and as Professor Lim has said, there is nothing ruled out and there is nothing ruled in at this stage. We will proceed at the speed of science and at the speed of data availability. Thank you all for your attention. This press briefing is now closed.